Thank you. Good afternoon. Let me start thanking the organizer for the kind and really appreciated invitation to be here with you and to discuss this topic that is, yes, related to pediatric immunization, but as I will show you, is also related to older people. So this is my disclosure of conflict of interest. As the chair already said, I'm a medical doctor specialized in hygiene, preventive medicine, and public health, and also in microbiology. And I worked and am still working on the epidemiology of vaccine-preventable infectious diseases. Let me start with this very general point of view, and I'm aware that you well know this point. But I must say that lifelong immunization is a key point in order to address the topic of my talk. And I must say that it has been already amply discussed and is still discussed at the European Pediatric Infectious Disease Congress that is still ongoing in Madrid, and where the key message was eat well, have a lot of physical activity, do not smoke, and vaccinate. And this is one point I should like to add to what was already said by the previous speaker. So lifelong immunization wants to cover all ages of our life by different vaccination. And this is a relevant topic because we have to invest in the future by vaccinating children and adolescents, but we have also to enhance productivity by vaccinating working age adults, and we have to achieve and guarantee a healthy aging to older adults. And we should make, or at least try to make affordable this new approach. And we must say that at the European level, there is a stronger than ever political leadership on this point. And this document by the Council of the European Union points out that it is absolutely relevant to consider immunization beyond infancy and early childhood by creating vaccination programs with lifelong approach. This means that from the point of view of the European Center of Disease Control in Stockholm, and as well as from the European community, there is a reasoning on this point. We want to raise awareness on the value of life course vaccination, and there are also some calls for European investments on this topic. What's going on at the local level, I must say the national level, and I'm very pleased to show you how is going on in Italy as a good example, because this is, what I'm showing you is the so-called lifetime immunization schedule. This is a document that has been approved and signed in by the Scientific Society of Hygiene, Preventive Medicine and Public Health I belong to, by all the Italian pediatricians and by all the Italian general practitioners. And this is a calendar, a schedule that includes all vaccination in every age class, and so this is, I think, a good example on how could be approached the problem or the issue of life course vaccination. I squared the part related to young adults and elderly, and in green is the part we are going to discuss later on. And it's also a pleasure to say that this is the national immunization schedule. This is included in the last, still ongoing, published last February National Immunization Plan, and more or less it includes all we have suggested as scientific societies. So, taking into account this introduction, we are well aware that if you use a vaccine, and we hopefully achieve high coverage rates, we have a great impact on the morbidity and on the mortality. But we also achieve a reduction, and in some instances, elimination of the spreading of the pathogen. And so we have to face this problem, and this is why we are talking about booster vaccination. Why we need booster vaccination? Because in some instances, the duration of protection provided by vaccine, but also by wild agent, is not long-lasting, and the ample use of vaccination has allowed us to achieve, in some instances, elimination or at least a reduction of natural boosters, and so the possibility to be reinfected by the wild agent. So from the theoretical and point of view, immunization should make immune a susceptible subject avoiding to become infected and sick. But in some cases, and diphtheria, tetanus, pertussis are good examples of this, we have to face another problem, that one that has been successfully immunized due to waning immunity, other issues, could become again susceptible, be reinfected, and became a subject that not only infected but also infectious. And this is one point that we should absolutely avoid, for example, talking about pertussis. So booster vaccination should guarantee the long-term protection of already successfully immunized subjects, and these subjects may in some cases be exposed to a new risk of acquiring infection or disease, and this in relation to the decay of immune protection, waning immunity, the lower possibility of natural boosters, that is a consequence of our high coverage rate, and the eventual possible reintroduction of an already eliminated pathogen. So the goals we want to achieve from now on are certainly to consolidate the success we have obtained, but also we have to evaluate the consequences of the immunological pressure we are exerting by vaccination in our countries. And we want, of course, guarantee the long-term protection. So, talking about tetanus, diphtheria, and pertussis, we can ask three simple questions. The first one, is there a long-term immune protection? And for all the three, the answer is no. Waning immunity is an issue. Have we achieved a decrease or the elimination of natural boosters? And it's not applicable for tetanus because it's zoonosis, and so the agent is widespreading all over in any country. But the answer is yes, because diphtheria has been eliminated, and is yes for pertussis because we have reduced we have achieved a huge reduction of the spreading of Bordetella. Is it possible to have the reintroduction of an already eliminated pathogen? The answer, at least for diphtheria, is yes, because it's eliminated in our country, in the European Union, more or less, as I show you later on. So let's talk about tetanus, diphtheria, and pertussis very briefly. Tetanus is the only non-communicable vaccine-preventable infectious disease, and in this case, the concept of herd immunity is not applicable. this is the the table from the WHO that shows us how has increased the coverage with at least 3 doses of diphtheria, tetanus pertussis with the pediatric content, high antigen content, full antigen content, and we have an estimate of 86% of coverage rate all around the world. We have more or less 10,000 reported cases, and we have 72,000 estimated deaths in children under 5 years of age. So tetanus continues to be a threat. These are data from Europe. In 2014, this is the last update that we can see in the website of CDC. There have been reported 84 cases of tetanus, and the notification rate was quite low. The most affected age group was 65 years old or above. There was a cluster of cases during the warmer months, and the epidemiology shows and confirms that tetanus is controlled diseases, but that some cases still occur in unvaccinated or partially vaccinated subjects, in particular female, as I show you later. And so the key message is that due to the severity of tetanus, there is still a need to maintain high vaccination coverage in all ages group, and to implement catch-up and booster strategies, at least where the higher rates of the disease are registered. This is the cases in Europe stratified by age classes. It's quite clear that tetanus hits particular older people, and in particular females. And these are the key messages from the ECDC. The notification is very low, and this is strictly related to the high coverage rates we have achieved in all European countries. The number of reported cases are slightly decreasing, and anyway, most cases are reported in the elderly, in particular during the summer months, but probably this is related to more outdoor activities during this part of the year. And despite the small number of cases, tetanus is still associated with a high mortality, and for this reason, vaccination and also post-exposure prophylaxis are mandatory, I should say. So the conclusion from the public health perspectives at the European level are, due to its severity, tetanus continues to pose a risk to unvaccinated people, and there is a need to maintain high vaccination rates in all age groups and to implement catch-up and booster strategies. Let's talk about diphtheria. This is another disease where waning immunity is an issue. Corynebacterium diphtheria has been eliminated in many countries, but if we look at the worldwide the perspective, at least 4,500 cases are still reported. The coverage rate is the same I showed you before, and so is increasing, but it's not optimal, but it's quite good all over the world. But anyway, diphtheria could be a devastating infectious disease, and at least in the past, some devastating epidemics have been registered mainly in children. From the European perspective, in 2014, 38 cases of diphtheria have been reported to the European surveillance system. 22 were related to diphtheria, and the other to ulcerans. And in any case, adults and elderly were the most affected subjects. And again, the majority of cases were non-vaccinated or under-vaccinated subjects, and in some cases, the vaccination status was not really known. And the key message, again, is that we have to maintain high coverage rates. This is the stratification of European cases accordingly to age, and most of these are in adults and elderly. And this is, allows us to use diphtheria as a paradigm on how we are able to change the epidemiology of an infectious disease using vaccination. For example, this is the slope of seroprevalence in the pre-immunization era, antibody passively given to the newborn by the mother. These are lost in 1 year. And then the contact with the wide pathogen is related to the increase of seroprevalence, and then there is a plateau because the natural boosters were ongoing. Nowadays, we vaccinate quite well our newborns, but if we don't adopt the opportunity to introduce booster vaccination due to waning immunity, the post-immunization era seroprevalence can look like this. And so has completely changed it in respect to the past. So in Europe, the CDC concludes that diphtheria toxoid vaccine effectively protects against the effect of the exotoxin. The target of immunization is exotoxin, but for diphtheria, we have also achieved a paradox effect of the elimination of the circulation of the pathogen that is not the target of the immunization. And since the reported vaccination coverage in Europe is quite high, the threat of a widespread outbreak is unlikely, but we nevertheless have the need to surveil and to have more complete data to maintain high vaccination coverage in the population well above the threshold in order to have, for example, herd immunity. And this is the reason why we have to improve vaccination coverage in under-vaccinated population, and among these there are also elderly. And we should pay particular attention to revaccination, for example, of healthcare and social worker, and to make to use revaccination of adult population, for example, giving a booster every 10 years. And this is the last part, is related to pertussis, that continues to be an important cause of death worldwide, at least in infants. As you can see, in 2013, the estimates by the WHO were 63,000 deaths in children under 5 years of age. The most recent data talk about 142,000 reported cases, and this means that pertussis is still around. And this is a problem we are facing also if, in Italy as well in other countries, we have achieved and maintained for a long time very high coverage rates. In 2014, at Europe level, were reported more or less 40,000 cases of pertussis. This notification, the notification rate was more or less 9 per 100,000 population. The last epidemic year was 2012. The stratification of cases shows us that pertussis is not still a pediatric infectious disease, and we have to face some new problems, as I'll show you later. The most part of cases under 1 year of age have included subjects younger than 6 months of age, and this is a crucial point from the prevention perspective. And in other words, we have to work a lot in order to maintain high coverage rate in the pediatric age, but we have a lot to do also in other ages. So after a dramatic decline at the European level, we are facing an increase of cases in any country. And this occurs despite the achievement of high coverage rates, and this is strictly related to waning immunity and possibly also to other issues. This is the picture from the European countries. The darkest the color, the worst is the epidemiological situation in the country. But I must underline that these data are amply underestimated, because we are very able to know what is ongoing in the pediatric age, but we have some issues like under-notification, under-diagnosis, and so on, in all other age classes. And so we are looking, and this was the data that I show you in the figure from Europe, on the tip of the iceberg, what we don't really know what is going under the water. This is the stratification of pertussis cases in Europe, and pertussis, as I told you, is no longer a pediatric infectious disease. We have most cases in adolescents and young adults, and an important peak of notification in the first year of life, in particular in the first 6 months of life. This is particularly relevant because a pertussis in an infant, in a non-vaccinated infant, or in an under-vaccinated infant, could be a deadly disease, as you well know. And what we have to avoid is that adolescents, young adults and elderly could acquire again pertussis and became infectious and transmit infection to subjects that cannot or have not already started the immunization course. So, in other words, the increasing incidence in adolescents and adults is a reason of great concern, because these age groups could be a source of infection to infants. And please bear in mind that pertussis in an infant and in the pediatric age has a pathognomic aspect, but in an adolescent, in an adult, and in an elderly is quite often asymptomatic and in a specific presentation. And so it's very difficult sometimes to make a diagnosis and to evaluate that we are facing, we have in front an infective subject. So the high coverage we have achieved has allowed us to greatly reduce the incidence, but we have made natural booster less frequent, and due to waning immunity, adolescents and adults are now the key in the transmission and the spreading of Bordetella pertussis in any developed country. So the public health conclusion from the European perspective is that pertussis is now the least controlled of the vaccine-preventable diseases. And this means that we have to work a lot in order to maintain high coverage rates in the pediatric age, but also to hardly work in all other ages during the life. And so this is the reason why many countries have already implemented different immunization strategies. That means that if we want to achieve a good impact on the pertussis, we should work on newborns, preschool children, adolescents, adults, healthcare workers, child care workers, pregnant women, and also apply the so-called cocoon strategy. In other words, prevention of pertussis requires an integrated approach and the adoption of different immunization strategies. For example, talking about pregnancy, this is one paper published in Human Vaccine during this year, and we underline that pregnant and new mothers should, in a very provocative way, should be vaccinated, and the use of boosters against diphtheria, tetanus, and cellular pertussis could and should be used in pregnant women as well in order to protect the newborn as well as the mother. So, this is one of the last my slides. If we look at how long immunization is, we are working in Italy on this topic. The story starts in 2001 with the decree, the 464, that recommended the use of boosters once you have completed your pediatric schedule with one dose at least of diphtheria, tetanus with adult antigen content every 10 years. In our national immunization plan 2005-2007, we have introduced the use of booster against diphtheria, tetanus, pertussis, as well as poliomyelitis with the inactivated vaccine at 5-6 years. And then we recommended for the first time a booster dose in the adolescent age. In the following National Immunization Plan 2012-2014, we have included also the use of the recommendation for boosters one booster every 10 years after 18 years of age. And this is, as I already showed you, the last still ongoing National Immunization Plan. And this is the mandatory course with the full antigen content diphtheria, tetanus, cellular pertussis included in the hexavalent vaccine. This is the last mandatory vaccination at the age of 6, and you can use this. This is the pediatric vaccine or the reduced antigen content vaccine as well. There is the recommendation for the use of diphtheria, tetanus, cellular pertussis, and also HPV in adolescence age, and then the recommendation for one dose every 10 years. Besides, there are recommendations for pregnant women, subjects at risk related to professional exposure, such as healthcare workers, and subjects at risk related to specific behaviors and or conditions. We can talk about cocooning, for example. An important point, everything is written in this slide is free of charge, and when there is something mandatory, there is also actively offered all over our country. So my closing remarks are the following. The distinction between vaccination schedules for children, adolescents, adults, and elderly is almost outdated, and we now need to think in terms of lifelong immunization. Taking into account tetanus, diphtheria, and pertussis, we must consolidate the already achieved successes, but we also take into account the immunological pressure we have exerted on the pathogens, and we should face the issue of waning immunity. And so we should be aware that boosters allow to guarantee over time the protection of already successfully immunized subjects and possibly newly exposed to the risk to acquire and or to transmit infection. Thank you very much for your attention.
Many thanks for your impressive speech. I'm Liang Yichen from Taiwan. I just have some questions. Thanks for the great advance in public health and vaccination programs. So few physicians can adequately identify the disease, including diphtheria, pertussis, and tetanus. So how to make sure the vaccine efficacy against the three diseases based on a solid diagnosis. I just wonder the question because...
So diagnosis is a problem. Not a problem probably for tetanus, but certainly for diphtheria. I must say that my students will never see, I hope so, have never seen and will never see a case of diphtheria. And so we are learning something in the books, but they are not able to make a diagnosis. We have already, of course, diagnostic tools, but the problem is that we have a problem in a correct and rapid diagnosis for diphtheria. For pertussis, the problem may be different because we have to change the way of thinking of our colleagues. Our colleagues now don't think many times about pertussis. I have a subject, an adult one, with cough, and cough is still lasting for at least, for example, 2 or 3 weeks. I give him something because I think he has a gastrointestinal reflux, some acidity. This was the last case I saw, and it was a young father who transmitted pertussis to his newborn, but was treated with, by his medical doctor from all other problems, gastrointestinal problems, so gastric problems, sorry. And so we have to change the cultural behavior of our, and this should be and will be a great effort we have to do in the future. There is some consensus, at least, international consensus on this point. It's a fact that waning immunity could be faster than 10 years. But usually making altogether diphtheria, tetanus, pertussis, probably we make a balance. But I don't think that in the epidemiological situation we have now, at least in Italy, we need more. If I understand, we need a more strict period. Yeah, okay, but the problem, yes, but the problem is, are we sure that we are already able to have each of us one booster dose every 10 years? Is there any doctor that to lay people speaks and say, you have to do a booster every 10 years? No. So we discuss when we have achieved that.
One final. It's just a very short comment. We have did a study in France for people 50 years and older going to the GP for a cough for 2 and 3 weeks. And we did PCR for bordetella pertussis. And we found a rate of 180 cases per 100,000 who were positive. So it's a real problem in the adults.
Okay, thank you very much. Much more.